So Dr. Ed Lifshitz is the medical director for the Infectious and Zoonotic Disease Program of the Communicable Disease Services at NJDOH, the Department of Health. In his role as medical director, he monitors reportable diseases and outbreaks in New Jersey and helps to develop and deliver guidance for the control and prevention of infectious disease outbreaks. He also helps to monitor for and provide guidance for potential episodes of bioterrorism, works to decrease the emergence and spread of resistant organisms, and also provides education and support to New Jersey's medical community. Dr. Lifshitz has been involved in the Department of Health's response to uncommon events like Zika and Ebola, as well as ongoing concerns such as healthcare-associated infections, or HAIs, influenza, and foodborne illnesses. Dr. Lifshitz graduated from the SUNY Downstate Medical School and is a board-certified physician in internal and adolescent medicine. Prior to joining the Department of Health, Dr. Lifshitz's career included 2 decades of direct patient care and over a decade in leadership and public health roles at Rutgers Health Services. So Dr. Lifshitz, I see that your slides are appearing. If you can go right ahead and get started. Thank you so much for joining us today.
Thank you. And thank you all out there for joining us as we talk today about antimicrobial stewardship and antibiotic resistance, a very important topic and very apropos given the season. And first, I just kind of wanted to start with how a typical visit to the doctor often goes. And just this little slide here, the patient's sitting on doctor's table, coughing away, and the doc goes, "Hey, lucky we caught this nasty little bug in time for me to treat it." The patient says, "Well, I guess I should be grateful for that." And the doc is, "You're darn right, because in a couple of days, it would have gone away by itself." What is antimicrobial stewardship? Antimicrobial stewardship can be defined in different ways, but basically it's a set of commitments and actions designed to optimize the treatment of infections while reducing the adverse events associated with antimicrobial use. And just a few things about that. We aim not to stop the use of antimicrobials. We aim for them to be used appropriately, both because it's better for the patient in the short term as far as side effects and ill effects, and for the community at large as far as resistance goes. Just another quick word here. Often you'll hear the terms antimicrobial and antibiotic, and while they're used synonymously often, sometimes even by me, they're not exactly synonyms, meaning antibiotics treat bacterial infections. Antimicrobial is actually a broader term that include antibiotics as well as antifungal, antiparasitic, and antiviral agents as well. Just a quick quote. Back in 1962, Sir Frank McFarlane Burnett, a Nobel Prize winner in medicine, said this: "One can think of the middle of the 20th century as the end of one of the most important social revolutions in history, the virtual elimination of infectious diseases as a significant factor in social life." Sitting here now, we can't really understand how important this statement was. Here he was saying that basically man had conquered our eternal enemy. We had managed to beat the microbes. Microbes, even before we knew what microbes were, shortened lifespans, killed millions, and now he was saying, hey, we've won this war. It's pretty much time for us to move on to other things. Let's talk about cancer. Let's talk about heart disease. Those infectious disease, those microbes, last year's news. So why 50 years later, do we have the director of the CDC, Dr. Thomas Frieden, saying, we are potentially headed for a post-antibiotic world in which we will have few or no clinical interventions for some infections? How did that happen? How did we go from thinking that we had won, that this was all done, to currently where people are worried about whether we have any agents left to treat some infections at all? Well, let's talk a little bit about that. And let's start by talking about microbes. We know that there are more of them than there are of us. There are about 1,000 billion more microbes than people. That's an awful lot of them out there. What most people don't know is that even in you, there are more of them than there are of us. For every one human cell, there are about 5 to 10 microbes in your body. And you can kind of, to them, human bodies are kind of like an all-inclusive resort where they eat, they socialize, they perform acts that can lead to procreation, but they rarely leave the area. And while they are tiny, very, very tiny. When you add them up, they weigh 100 million times as much as people. So they're awful, awful lot of out there. And they've been on Earth a lot longer than us, about 1,000 times longer than us. And this is important because we don't really so much as discover new antibiotics and antimicrobials, or I should say we don't so much as invent them as we do discover them, meaning throughout their history, microbes have been exposed to these agents and similar agents, and they've had to learn to evolve, or they would have been wiped out and would have been destroyed. We also know that microbes generate a whole lot faster than we do. They can go through a generation in about 30 minutes. It takes us 30 years. That's a huge advantage when it comes to evolution and change. And, you know, PowerPoint is a visual medium. And to try to visualize this advantage, I came up with this little thing here. You know, if you look at this kindly gentleman here, you know, roughly 80 years old or so, he was born pretty much just about when antibiotics first began to come in use in the world. Well, in his body, the microbes that grew up with him, who reproduced every 20, 30 minutes in his body, have gone through about 1.5 million generations. That's about the same number of generations as man has gone through to get from Homo ergaster to today's modern man. Or to put it another way, if you took a look at Homo ergaster here and you just go through his 1.5 million generations, through all the survival of the fittest evolutionary challenges to finally arrive at today's much more evolved man. And you can see how long and hard evolution has to work. Let's talk about antibiotics. Before people knew what bacteria were, or what microbes were, or what was killing them, they knew about infections, and they knew that people were dying of infections, and they attempted to discover ways to treat those infections. The ancient Egyptians, going back about 3,500 years ago, tried to use things from mold, honey, lard, lint to treat infections with minimal success. When we headed into the Dark Ages and so forth, bloodletting became in vogue, and it was very popular to try to drain blood to treat infections. And while that may have had a minimal impact, it certainly was not overall very effective. Mercury was used. Mercury is toxic to many cells, including the bacteria that cause syphilis in particular, and it was a little bit effective, but you know what? Mercury is also toxic to a lot of other things as well, including all the human cells in there. So it was very difficult to just kill the bacteria or the organisms we didn't want without killing the human bacteria. And this is why, in 1910, when Paul Ehrlich first invented the first relatively modern antibiotic, salvarsan, which is an arsenic-based chemical compound that could cure disease without destroying all the human tissue around it, this was a major breakthrough. I mean, it's such a major breakthrough that, you know, Hollywood went and made a movie about this called The Magic Bullet. And of course, the disease that this treated was syphilis. Now, salvarsan was difficult to mix and administer. It had many side effects and no longer in the market today. Moving on, Gerhard Dammek, a German chemist working at Bayer, he had this idea, and his idea was this. We know that bacteria can pick up dyes, things like gram stains and so forth. If we could develop a dye that not only do the bacteria pick up, but killed them in the process, that would obviously be a good thing. And he worked with commercially available dyes. These were dyes that were used to dye clothes. And he found that one of the red dyes, happened to be a sulfonamide, was successful at killing some bacteria. And this became the first commercially available antibacterial agent that was out there. Of course, the one that we hear about was penicillin. This was discovered by Alexander Fleming back in 1928, but it took another 14 years until it could be purified and mass-produced in such a way that it was able to be used in any sort of quantity at all. An incredible drug, an amazing breakthrough that changed lives dramatically. In 1942, the first patient treated in the United States, Ann Miller, who is shown here in this picture, by the way, was a 33-year-old mother of two who had a streptococcal sepsis. She'd been running fevers between 102 and 106 for weeks. She got the best medical care of the time, including 2 surgeries to try to keep the infection from spreading, and nothing worked. She was near death. She was given penicillin, and it was truly a miracle. She was afebrile in a matter of days, left the hospital within a week, and lived to be in her 90s. Truly an amazing feat. This was back in 1942. Now, what else was going on in 1942? Well, there was a war going on. And throughout history, more men have died from battlefield infections than they have from battlefield wounds. In World War II, this began to change to an extent, and penicillin became the miracle drug of the war, where thanks to penicillin, he will come home. And it truly made a difference as far as that went. And when he came home, of course, the men sometimes brought back more than war stories. And we found that penicillin could treat many other things too, including things such as gonorrhea. Quickly, this led to what I call the golden age of antibiotic drug discovery, when through the 40s, 50s, and into the 60s, multiple new drugs and new classes of drugs were discovered. One of the things I want to point out on this slide is that nalidixic acid, which is the parent compound in the quinolones, was discovered back in 1962. This is actually the most recent class of antibiotics we have that can treat gram-negative infections. We've had more recent gram-positive infection treatments, not a lot, but some, but we're dealing now with using drugs that were first discovered almost 60 years ago to treat gram-negative infections. Over time, through the 80s, into the 90s, and into the new century, the discovery of new antibiotics dropped dramatically. Why was this? Well, a variety of reasons, but for the most part, it came down to this. Antibiotics are not very good business, meaning it costs hundreds of millions of dollars to discover, take through clinical trials, go ahead and market a new antibiotic. And then what happens? If you're successful, that antibiotic is only used for a short period of time. It's not like a drug like Viagra, which people need to use continuously, or a Lipitor for the cholesterol, or a great new diabetes treatment that people are going to stay on forever. You're only using it for a very short period of time. And on top of that, then you're going to have people like me who are going to get up and tell people, well, you know what? Don't use this great new drug because I don't want to be resistant to this. Only use this as a last resort. The overall market is quite small. If we look at mortality rates in the United States over time, what I want you to look at here in particular is this bottom line, this pinkish purplish line here that shows death from infectious diseases. And what you see is going back to the turn of the last century, there's been a gradual but steady decline in the deaths due to infections. Now, early, almost all of this was due to increased public health, better water supplies, safer food, as well as things like immunizations. Now we get it around 1940 when penicillin is introduced, and you see that infectious disease death rates continue to drop over time until we get about to the 1980s when rates not only flatten out, but they begin to rise. Most of that rise is related to the new infection that was first came epidemic in that time, and that was HIV/AIDS, but we're not making any more progress as far as deaths from infectious disease goes. And by the way, this one big spike you're seeing back here in 1918, that was the great Spanish pandemic flu outbreak of 1918. So let's talk about antibiotics and how they're used and sometimes misused, and what's the harm when they are misused. Well, I'm going to start by telling you that an awful lot isn't known. We don't know exactly how many antibiotics are taken by people, and we don't know how many antibiotics are taken by animals, although we do know that animals take more antibiotics than people do. Why do animals take antibiotics? Well, it's not that their health plans are so good that there's no copay or anything. They're used in animal use for different reasons. I mean, they can be used therapeutically. Animals get sick. They get the same bacterial infections that people do. A lot of the same antibiotics can be used to treat those illnesses. These are expensive animals. It makes sense to go ahead and do that. Sometimes also given as prophylaxis, meaning animals are sometimes raised in very crowded, somewhat inhumane conditions, which makes the potential for spread of disease very real. And the thought is, well, I'm just going to go ahead and put all my herd on antibiotics, and hopefully if an infection occurs, they won't spread throughout the herd. However, traditionally, certainly in the United States, the large majority of antibiotics were used for non-therapeutic reasons, and that is because they were found to be growth promoters. Exactly what the mechanism and the total effect isn't clear, but it seems to hold true for most antibiotics. If you give mammals antibiotics regularly, they will gain weight faster, they'll grow to be bigger and fatter. And by the way, as an aside, while the epidemic of human obesity is certainly multifactorial, one of the thoughts as to one of the reasons why more children are obese now than in the past is the very common use of antibiotics in children. So in response to this, the FDA began issuing voluntary guidelines back in 2013, which went into full effect in 2016, which basically said that antibiotics should no longer be used as growth promoters. They could still be used to treat illness, occasionally as prophylaxis, depending upon the situation. But basically, we're going to say you can't use it as growth promoters anymore. And the good news is that we are seeing some decline in the use of antibiotic use in agriculture. This graph here is showing number of antibiotics used agriculturally over time, that's the tetracyclines being the largest group that are used. And what you saw was up until about 2015 or so, use increased. Now, just in the last couple of years, 2016, 2017 being the latest data that's available, those numbers are decreasing. So the good news is that they are decreasing. The bad news is that there are still a significant amount of antibiotics being used in animals. So what? Why do I care? Why do I care if farmers go ahead and use antibiotics? It makes the meat cheaper for me, makes more money for them, all good, right? Well, no, not really. We care because we know that when we feed animals antibiotics, that they themselves breed resistant organisms, and that those organisms don't stay with them. They get shed into the environment. They go through the food chain, either when we eat our chicken that's been contaminated with salmonella, or directly in farms, direct contact or contamination of water in fields where workers walk through the farms and pick up bacteria on their feet and bring them home to their families and then share them with their families. And this has been shown for a number of different organisms. And I can tell you this, I practiced medicine for a long time, and I can tell you in all that time, never once did I have a cow walk into my office and ask me for a Z-Pak. People, however, people are a very different story. In fact, as Sir William Osler, one of the true giants in medicine, said, the desire to take medicine is perhaps the greatest feature which distinguishes man from animals. So what do we know about people? Well, I'm going to start by saying that estimates vary, but I'm going to go with about 50% of all antibiotics used in this country for people are unnecessary or inappropriately prescribed. So about half the time it's being done appropriately, and about half the time it's not. We know that if you look at the risk of being given an antibiotic in the United States, and it is a risk, I'm going to talk about what some of those risks are in a minute, and we compare it to the rest of the world, we see some interesting things. We see that overall, Europe has a lower risk than the United States. Antibiotics are used less commonly. And in fact, if you compare the United States to the Netherlands, you have about twice the risk of being prescribed an antibiotic in the United States and the Netherlands. And this isn't because the Netherlands are people there, the Netherlanders are naturally hardy and don't get bacterial infections, so they don't need antibiotics. And it's not because they're dropping dead at the age of 12 because they have sepsis and other bacterial infections. It's because antibiotics are overused in the United States. And I guess the good news is we do better than some countries in Europe, such as Italy, France, and Greece, and we do better than some parts of the world where there are no controls at all, such as much of Asia and other places as well, but there's a lot of room for improvement. And even in the United States, your risk of being given an antibiotic varies widely depending upon where you're at. For example, New Jersey is slightly above the national average as far as prescriptions given per 1,000 people. So we can say, hey, we're a whole lot better than Kentucky. But we're also a whole lot worse than Alaska, not to mention most of the West Coast where antibiotic prescriptions are given at much lower rates. So what? What do I care? How does an unnecessary antibiotic prescription harm an individual? Well, there's harm several ways. First off, there's the cost of the antibiotic itself. A lot of these things aren't cheap. You got co-pays, out-of-pockets, you got insurance payments, of course, and if the insurance is paying for it, guess what? That means I'm paying for your prescription, which you didn't need, and so forth. So cost itself is significant. You have side effects from the antibiotics. These are immediate side effects like nausea, vomiting, mild things, diarrhea, occasionally severe, such as anaphylactic allergic reactions. So you have those side effects. You have C. difficile. I'm going to talk a little bit more about that in a minute. Those are very clear. That's very clearly associated with antibiotics. And then you got colonization and infection associated with resistant organisms. Because you know what? When I give you an antibiotic, I'm helping to breed resistant organisms in you. The CDC looks at these things regularly, of course. A few years ago, they put out what's known as a vital sign talking about C. diff in particular. And what they're showing here is that almost all C. diff infections are connected to medical care. Again, we'll talk about that in a moment. And that number of hospital stays related to C. diff have tripled over the last decade or so. And that if you do appropriate infection control in hospitals, you can significantly decrease the risk of C. diff. So let's talk about C. diff. And first off, I'm going to tell you that C. diff has actually undergone a name change. The formal name for C. diff is Clostridioides difficile. It used to be Clostridium difficile, but every now and then we like to change names just to confuse people, but we kept the same genus, so we didn't have to change the C, so it's still C. diff. But antibiotic exposure is the single most important risk factor for C. diff. Why? Because here's what happens. Here's how somebody gets C. diff. It's almost always a combination of two events. First is we go ahead and we expose them to the C. diff spores themselves, so they have to get exposed to C. diff. Where do the C. diff tend to hang out? It tends to hang out in places where people are sick. Where are people sick? Well, doctors' offices, hospitals, those sorts of places have a lot of sick people and a lot of C. diff spores hanging around with them. Then what do? Then we give them an antibiotic. What does the antibiotic do? Well, an antibiotic wipes out an awful lot of those bacteria in the gut that we were talking about before, but not C. diff usually. So what happens? Now you get rid of all the so-called good bacteria, you expose them to C. diff, and C. diff goes to town. They're like, hey, you know, there's no competition here. I'll go ahead and I'll multiply, and that's what happens. So we create C. diff almost all the time by first exposing patients to C. diff and then wiping out their means to naturally fight off C. diff themselves. Overall, if you look at every patient admitted to a hospital for any reason, this includes everything from women having birth to MIs to car accidents to pneumonias and other things, overall, about 55% of all inpatients will receive an antibiotic. About 1% of those patients will acquire C. diff, and about 10% of those who acquire C. diff will die. This is not a minor inconvenience. This is a serious medical issue. If we look at C. diff rates over time, you see that the bad news is you had this big jump going back into the turn of the century where C. diff rates increased dramatically. The somewhat good news is if you look past 2009, these rates are flattening out. They're not dropping very much. So we're kind of holding at a higher level than we had been in the past. Very serious issue. What about the individual? Well, again, use of antibiotics in an individual has been shown to breed resistance in that person. It's been shown to breed resistance in urinary and respiratory bacteria, and that giving somebody an antibiotic can impact bacterial resistance in them for up to 12 months, and that the more antibiotics I give you and the longer I leave you on antibiotics, the greater the likelihood that resistant bacteria will be isolated from you. And these are messy slides that you don't really need to pay a whole lot of attention to, besides for let me kind of just point out this. This is looking at respiratory tract bacteria. These are people given antibiotics. These are different studies. And basically everything to the right of this vertical line here are studies that have shown resistance in those patients. Very similarly, looking at urinary tract bacteria, same types of studies. Everything to the right of this vertical line shows resistance in patients who are giving antibiotics in urinary tract bacteria. And finally, similar type thing, but this is over time. This is, again, your baseline here, and this is looking at resistance in people to respiratory tract bacteria over time after giving an antibiotic. And what this is showing is that over time, this is at 1 week up to 6 months, resistance gradually returns back to the baseline, but never quite makes it there. So what? Dr. Jones goes ahead and inappropriately prescribes antibiotics to his patients. How does that affect me? I mean, I know it affects his patients. I know it's costing them money. I know it might be making them ill. I know all those sorts of things. But how does that affect me? Well, it affects me because when somebody gets a infection with one of these resistant organisms, they are sicker, die more frequently, and are more expensive to treat than somebody who does not have one of these infections. We know that there are about 2.8 million infections every year with antibiotic-resistant bacteria and fungi, and that about 35,000 deaths are associated with this every year. If we go ahead and we added in C. diff to these, you can add in another 12,800 deaths and so forth. So you can see the graphic. It's a big issue throughout the country. Just in the last couple of weeks, the CDC has released their new antibiotic resistance threats in the United States. And basically, what it shows is a whole list of organisms here that are either considered urgent, serious, concerning threats or watch lists. And basically, as you can see, there are a lot. Again, what's the harm for me? We mentioned some of it before. It costs a lot to go ahead and treat those patients with antibiotics that didn't need it in the first place. And then when they get sick with one of these organisms, it treats me a whole lot to go ahead and treat that infection. These costs are estimated just for treating these infections at roughly $20 billion per year. And finally, it hurts me because you know what? While half of all antibiotics are not prescribed appropriately or not needed, half are. And you know what? I'd like to be able to count on that antibiotic working for me one day when I really need it to. Here in New Jersey, we see multi-drug resistant organism outbreaks all the time. This is data from back in 2017 when we see outbreaks related to carbapenem resistant organisms, Candida auris, other resistant organisms as well. And one of the things that we're beginning to notice in New Jersey is historically, most of these resistance organisms were seen in patients who had traveled elsewhere. You know, they'd gone to Asia, they'd gone to the Far East or the Middle East, places where resistance is more common, and then they brought back the bug with them to New Jersey. Now we're beginning to see more patients who are only treated in New Jersey healthcare settings, meaning that we think they're picking them up in New Jersey. Also in the news recently and in the past, and you'll be hearing more about it in the future, is Candida auris, a so-called superbug fungus, which is an issue in much of the country, including New Jersey as well. We're seeing a lot more of these types of lab reports. We don't like to get these types of lab reports. And what you're seeing in these lab reports is, you know, all these R's here are all saying resistant. So these are all antibacteria that this particular organism happen to be resistant to. We're lucky that there's still an S. We're lucky that we're occasionally seeing an S in most cases here. 10 years ago, those would have been almost all S's. So we're seeing that we are losing the antibiotics that we need to treat this. As mentioned, of course, we're not just talking about bacteria, we're talking about viruses too. We know that HIV and flu become resistant rapidly. Parasites, malaria, one of the big killers in the world, becomes resistant quite rapidly also. We're running out of agents to treat that as well, and we're continuing to need to change agents for that. Funguses, as mentioned, Candida, such as Candida auris, are a very real issue. Quick comic relief. Shows a bacteria walking through. Hey kid, want to become a superbug? Stick some of this into your genome. Even penicillin won't be able to harm you. It was on a shortcut through the ICU that Albert was first approached by a member of the antibiotic resistance. Not entirely inaccurate about how some of resistance happens. So let's talk about outpatient and outpatient antibiotic prescribing. Again, I'm going to start off by saying that approximately 50% are unnecessary. Why? Why are so many unnecessary antibiotics being prescribed? You know, are doctors stupid? Don't they care? Don't they learn? Don't they come to lectures, don't all those sorts of things? Well, there are a lot of reasons, and these are legitimate reasons. And if this was an easy problem, it would have been solved. Beginning with the fact that, you know what, it's a whole lot quicker to write a prescription and hand it to a patient and say, hey, take this, call me in a week if things aren't better, than to explain why you're not giving them that prescription. Why, even though the last 4 times they went to a doctor for their bronchitis, they got an antibiotic and that always worked, that you're not going to give them an antibiotic, even though that they took the day off from work just to come to see you, just so they can get this antibiotic, and you're not going to give it, and you're a fool. So that is a very real issue. It's also a very real issue that there is diagnostic uncertainty. You know, if I'm treating patients in the middle of the flu season, an awful lot of people are walking in with fevers, I can be pretty sure that most of them have the flu and won't benefit from an antibiotic. But you know what? I might not know for sure that there is not one of them that really has a bacterial infection, a sepsis that needs to be treated. And I give this talk before and fairly often to doctors, and I gave this talk once, and he came up to me after the talk and he said, you know what, I hear everything you're saying, I understand all that, but you know what, I give antibiotics a lot. I'm going to continue doing that. Why? Because I'm worried about malpractice. I'm worried about these guys. Well, not really so much these guys, but this guy, the creator of those other guys. And I'm worried about this, that Jim Henson was 53 years old. He was a generally healthy person. He went to the hospital. He wasn't treated possibly as aggressively as he should have been. He ended up dying of a streptococcal sepsis right after that. And the doctor says to me, you know what? Yeah, I know that I'm treating, 9 out of 10 don't really have a bacterial infection, but I'm not going to take the chance that the one I miss really had a bacterial infection, and I'm going to end up getting sued because I missed it. And to that doctor and to other doctors, I say this. The best defense against malpractice is to do the right thing. And then if you look at doctors who are sued for medication-related malpractice claims, the number one reason why doctors get sued related to medications is the inappropriate use of antibiotics. Meaning you put somebody on an antibiotic who had an adverse reaction. And I'm going to tell you this, that if you just do a very quick search on the internet, it's pretty easy to find just a few lawyers out there who are very happy to sue a doctor over an antibiotic that was used when it wasn't absolutely needed and went ahead and caused an adverse reaction. So basically, what I tell people is, do the right thing. Take care of the patient. You can get sued either way. There is a general feeling that newer equals better, that, hey, this great new antibiotic's got to be a whole lot better than amoxicillin, because whoever even gives amoxicillin anymore, that's not on any pens, it's not repped by the pharmaceutical agents or any of those sorts of things. But those newer agents are broader spectrum and they're very commonly overused. We really want people to use a narrow spectrum antibiotic whenever possible. They're the perceived and actual patient expectations. Means doctors either think that patients are there because they want that antibiotic, as I talked about before, or the patient really does want that antibiotic, and doctors don't want to disappoint the patient. They want the patients coming back. They want them being happy with them. They want good survey responses. I've heard doctors tell me, hey, my hospital looks at patient satisfaction surveys, and if I don't give that patient that antibiotic, I'm going to get a bad patient satisfaction survey. And a very quick anecdote, even in my family, not too long ago, I got a call from my mother-in-law who went to see her doctor, had to see her PA instead, which she wasn't happy about, for her sinus infections that she gets every year, and her PA refused to give her an antibiotic. She came home and called me and complained about that fact, and how, this PA doesn't know anything, and how she hated not seeing the doctor, and how unhappy she was. And all I said was, I'm going to send that PA a thank you note. That's exactly what they should have done when that comes. And of course, doctors want to do something. They do want to help. And there's an awful lot of, what's the harm? We give antibiotics a lot. I don't actually see those antibiotic resistance growing in my patients when I give them. I might know that that's happening, but I don't actually see it. So we think, what's the harm? And I'm going to tell you that where you go makes a big difference. This is a little bit confusing graph here, but basically what it's showing is this. The VA did a survey where they looked at what was happening to patients who showed up with acute respiratory infections in their outpatients clinics. And what they found basically was that, you went to some doctors, you were almost 100% certain of getting an antibiotic. Other doctors almost never gave antibiotics. And then overall, doctors who were in the top 10% of prescribers prescribed antibiotics at more than twice the rate of doctors in the bottom 10%. So again, it's not that the patient populations are different, it's that the doctors are different. And other things drive demand as well. You know, you see advertisements out there for so-called free antibiotics. You know, just look how happy that mother is with the daughter. You know, you can tell that she feels great about the fact that now she's able to take care of her daughter and make her feel better, and never mind the fact that it may not have been necessary and other issues may be coming from that. And of course, studies have shown that free antibiotics, are not necessarily a good thing at all. And what we don't want our doctor's offices to turn into is something like this, where the receptionist just says, hey, don't forget to take a handful of our complementary antibiotics on your way out. So who are these overprescribers? Well, obviously, there's no way to know, and surprising to many people, there's no way that we know who those doctors are in the state or elsewhere. But basically, overprescribing doctors in general tend to be doctors who have been out in practice for a longer period of time. They tend to be less academically inclined. They tend to be busier, meaning if you're trying to move 8 patients an hour through your practice, you can't spend the 5 or 10 minutes it might take to talk to a patient about why you're not giving them an antibiotic. And the so-called self-described poor diagnosticians, the ones that say, do I hear something in the lungs? Don't I hear something in the lungs? You know what? I'm just going to give them an antibiotic and not worry about it. So let's talk about the inpatients. Now, certainly in the inpatient side, you would think that antibiotic use would have to be a whole lot better. After all, you know, they got the experts there. They got infectious disease doctors. They got doctors there all the time. You got people wandering around. It should work a whole lot better. I'm going to tell you that, well, first off, as mentioned before, that over half of all patients who are admitted for any reason to a hospital will get an antibiotic. So they're used incredibly commonly. And what you see in this graph here is that most of the antibiotics that are being used are the newer, broader spectrum antibiotics, the so-called bigger gun antibiotics. About 4 antibiotics make up all the make up about half of all antibiotics that are given via intravenous. These, again, tend to be broader spectrum, bigger gun antibiotics. And we see this across all different hospital types. Overall, inpatient, similar numbers. We believe that between 20 to 50% of all antibiotics in a hospital are either unnecessary or inappropriately used. Why is that? Well, a patient might appear to have an infection that's treatable by antibiotics. It can be very hard to tell whether bacteria that you find in a bladder is just colonization for which you should not treat at all because it will come back, or whether that's truly the cause of an infection that should be treated. Similarly, scarring on a chest x-ray may look just like a pneumonia may look. So sometimes you may not know for sure. We also know that there is pressure for clinicians to go ahead and start an antibiotic soon after a patient enters the hospital. If they don't, if they wait, they can be dinged on report cards, and it's often considered to be better to start an antibiotic soon and then stop it later, although sometimes it's forgotten to be stopped, than it is just not to have started it in time. And there's a surprising lack of knowledge. You see duplication of therapy when it's not needed, 2 different antibiotics used when one is needed. Overly broad spectrum is very common. You know, when a patient first is admitted to the hospital, you don't know what's going on for sure. You can start with a broad spectrum antibiotic or groups of antibiotics to treat all possible infections. But then when you begin to get cultures back and you begin to see what is likely wrong with the patient, the therapy should be changed, and very commonly it's not changed. The wrong antibiotic is unfortunately prescribed too often. The wrong dose, essentially treating a 80-year-old, 80-pound woman the same as a 20-year-old, 250-pound football player. You know, not the same bodies and not the same dosing. And keeping people on antibiotics for too long is extremely common. Over time, we've moved more and more to shorter periods of time on antibiotics. We really want to get people off of antibiotics, particularly off of IV antibiotics. The sooner you get somebody off of an IV antibiotic, the sooner you can get them out of the hospital. And hospitals are not good places to be, particularly when you're sick. You don't want to be in the hospital. You want to get home as fast as you possibly can. Nursing homes, another place where antibiotics are commonly used. And we know that there are about 4.1 million Americans admitted or reside in a nursing home in a year. That's an awful lot of Americans. And even more of them get antibiotics than the people admitted to hospitals. We know that up to 70% of all antibiotics, of all nursing home residents will receive an antibiotic during a year. 70% or 7 in 10. And even more of them didn't need them. Either it's the wrong dose, the wrong duration, or the wrong reason. And there's a whole variety of reasons why that happens, beginning with the fact that you don't have on-site doctors regularly, that it's often very easy to say just because you see some bacteria in a urine sample that I'll go ahead and I'll treat the infection, even though it's not really an infection. There's often pressure from families and other things as well, but incredibly overused in nursing homes. Now, when we talk about antibiotics in general, of course, one of the hard things about this is that we're not trying to get to zero. Nobody is saying that antibiotics should not be used. These are truly wonder drugs. We should truly be using them. We should be using them in the right patients. You know, we don't want to get into this situation where we just, you know, completely ignored his symptoms and nicknamed him Sneezy and didn't treat the real problem. So we do want to go ahead and use antibiotics, but we want to use them appropriately. And of course, that's where antimicrobial stewardship comes into play. Antimicrobial stewardship is a broad name, and again, sometimes you know antibiotic stewardship, sometimes antimicrobial, and it's programs that are really promoted by the CDC and other organizations. They are promoted to 3 broad areas that we kind of mentioned about before. Outpatient, inpatients, and nursing homes are all somewhat different, although somewhat the same when it comes to how they're being managed. And they all have the same general goal, and the same general goal is this: to teach and increase the use, appropriate use of antibiotics and other antimicrobials. Why? Because first and primarily, we want to increase patient safety. We want to decrease adverse effects, especially including C. diff, as well as other things as well. And as an aside to that, we want to slow the emergence of resistant organisms over time. If we can save the patient or the system or the hospital or somebody else money while we're doing it, that's nice also. That's not the primary goal, but that certainly is helpful as well. What does this mean? Well, very briefly, I can tell you that in the hospital, stewardship has been shown to decrease C. diff infections. Here is a chart that shows basically the hospital said, hey, you can't use fluoroquinolone antibiotics anymore without special permission. And you see a sharp drop off in the number of C. diff infection rates right after they did that. It has been shown to reduce resistance. Again, in a hospital, this is looking at, again, antibiotic restrictions where the hospital said, you know, we're not going to let you use just any antibiotic you want. You're going to have to use either the older narrower spectrum antibiotics, or you're going to have a good reason to use one of those new big gun broad spectrum antibiotics. And they did show that they decreased the amount of resistance to those big gun antibiotics in organisms in the hospital as well. And it has been shown to save money, up to $200,000 to $900,000 a year. Even in New Jersey, it's been shown to save money. And basically, this comes about because, you know what, if we buy fewer of those expensive antibiotics, that saves us a lot of money. And of course, if we cut down on those expensive infections that people get when they get resistant organisms, that saves us money as well. Antimicrobial stewardship programs, at this point, all acute care hospitals should have them. The CDC began recommending that. That happened in 2014. Joint Commission made it a standard in 2017. In 2017 as well, the New Jersey Hospital Association began a statewide antimicrobial stewardship collaborative. They're doing some great work over there. And basically, we understand that while there is no single template for all institutions, meaning that there's no single form that everybody can use, everybody's a little bit different, there are some general things that everybody should follow. And basically, we want all hospitals to be following what are known as the core elements of an antimicrobial stewardship program, and that includes things like making sure that there's leadership support, that there's accountability, that in other words, doctors know what prescriptions they're writing and whether they're overusing or not. There has to be drug expertise, infectious disease experts, and pharmacists around it can help as well. There have to be interventions that can be taken so that that will go ahead and lead to the decrease in antibiotics, whether it's limiting the use of antibiotics as mentioned before, in the hospital or other things. You have to track what's being used and who's using it. And again, report back to those people what's being used and educate as much as possible. Nursing homes, they're more varied even than hospitals are. We know that there are a lot of different settings and resources out there. Basically, the plan should have the same elements of the hospitals. The implementation may vary somewhat. We don't want anybody really to try to go from 0 to 60 in a very short period of time. You're asking people to change a lot of processes, a lot of how they do things and so forth. You throw too much at them all at once, it can lead to a lot of resistance and difficulty, resistance in the people, not resistance in the bacteria, but never mind. So you do want to more gradually implement. In the outpatient world, same general thing. You know, there are the same core elements that come around: commitment, action, tracking, and reporting, as well as education and expertise. Now, of course, we realize that while the narrative that I've been describing may not be the greatest story ever told, it did lead to the creation of the current holiday, the one that was mentioned earlier today, which is the centerpiece of the holiday season that we're currently in, U.S. Antibiotic Awareness Week. I know that my family looks forward to this week every year. You know, we watch a traditional firework display, we light candles, we sing songs, we exchange gifts, and the children follow the great tradition of writing letters to their doctors asking if their last antibiotic prescription was truly necessary. I hope you'll join us in this celebration. And finally, I'd like to end with two quotations. The first by Sir Alexander Fleming, the discoverer of penicillin, who back in 1945 said, "The microbes are educated to resist penicillin, and a host of penicillin-fast organisms is spread out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organism. I hope this evil can be averted." Way back in 1945, 3 years after penicillin was first introduced into the population, it was already recognized that we could be breeding resistance to these drugs. We were already realizing that this could be an issue for us. And of course, we were not the only group that was realizing that this could be an issue. For in 1997, in the graduating class, the graduation speaker said, "You are the next class of drug-resistant bacteria. As humans continue to abuse and overuse antibiotics, your ranks will swell. So go out there and mutate. And remember, that which does not kill us makes us stronger." Thank you. And we are here to answer any questions you may have.
Thank you so much, Dr. Lifshitz. We appreciate the cartoons at the end as well. We do have a couple of questions to ask. The first one, I am going to ask the individual who wrote it just to ensure that I'm pronouncing this correctly. I'm not sure if this was a typo or not, but the question was, is the McGeer criteria the best tool to use before prescribing antibiotics? I'm not sure if McGeer is the correct term or if that might have been a typo. Is that correct? Is that the right term?
Yes. What the questioner is asking, and really this is the broader question that all clinicians ask, which is, okay, you're telling me that I should only use antibiotics when appropriate, and you're telling me that I'm using them oftenly when they're inappropriate. How do I know when it's appropriate? And people have come up with a bunch of different criteria or other tools to try to estimate the risk, essentially, about whether this is likely going to be a bacterial infection versus a viral or other infection that could be causing the problem. People are also looking at new diagnostic testing, meaning, you know, the truly pie in the sky, at least for the outpatient population, is a quick, simple test that will let me know whether a person is having a fever because of a bacterial infection, a viral infection, or something else. People try to use things like C-reactive protein, other testing as well to make that decision. And the short answer is whether any particular tool is the single best to decide whether to use an antibiotic, they all play a role. I wouldn't comment or rely on any single tool that's out there, but guidelines and criteria published by professional societies are extremely helpful. So certainly I'd be looking at those sorts of things. And of course, one of the reasons why we call them guidelines and tools and those sorts of things is because nothing is ever 100% accurate, but some of them can get very good. And that's kind of my longer way round answer to that question. So the short answer is yes, I think it's very helpful to say, is it the best tool to use? I'm not sure I'd call it the best. I'm not sure there is a best.
Okay, thank you. The next question is, when an antibiotic from a particular class of antibiotics, if that proves to be resistant to an infection, does that mean all of the antibiotics in that particular class would also likely not be effective? Or does it really vary even within the different types?
Well, antibiotics are in classes because antibiotics in those classes tend to share certain characteristics. And one of the characteristics that they tend to share is that they will typically treat a similar type of bacteria. You know, certain classes of antibiotics will treat gram-positive bacteria, other gram-negatives, and so forth. So there is a tendency that if you're resistant to one antibiotic in a class, that you'll be resistant to others as well. But it is just a tendency, because even within a class, there are small differences between antibiotics, and sometimes a different antibiotic in that class will still be effective. So the answer is, again, I would be going by the resistance pattern that my lab is giving me, where they're telling me specific antibiotics that it's resistant to. If I saw, because you can't test for every single antibiotic in a test, if I saw that something was resistant to an antibiotic in the same class, it would certainly lead me to believe that it was a lot more likely that it's going to be resistant to others as well.
Okay, thank you. The next question is, should a broad spectrum antibiotic be prescribed IP or PO while waiting for peritoneal fluid culture and cell count results?
That's a very specific question. And when you're talking about giving an antibiotic IP and how much is systemically absorbed versus not, those are other issues. Here, let me kind of give a broader answer. There are times when it is perfectly appropriate to give a broad spectrum or even multiple broad spectrum antibiotics because you don't yet know what is going on. Whether it's because you just tap somebody who you're worried about peritonitis, or a patient hits the emergency department who you're worried about sepsis, and you may have suspicions, but you do not yet know for sure. Everybody would say that it's appropriate to give every antibiotic that you think might likely treat that infection. The big thing, or the big thing that we want to make here is, well, first off, most cases aren't that, of course, but even in those cases, once you begin getting test results back, once you begin getting cultures back, once you begin seeing sensitivities and so forth, then it's no longer appropriate to leave them on 3 big gun broad spectrum antibiotics, but then the therapy should be narrowed down to what is treating that specific organism.
Okay, thank you. We have one more that I think might be a follow-up in some way to that. So if a lab result comes, oh, I'm sorry, actually that's the second one. Let me go back to this one. First off, the best online training I've attended in a long time for you, Dr. Lifshitz. So thank you for that feedback, Kaylee. The question is that in the case of meningococcal disease, there's evidence that early use of antibiotics is key to survival before waiting for the diagnostic tests results. So how does antimicrobial stewardship fit in with this specific infection? I wonder if maybe what you just said might apply there.
The short answer is yes. If you have any suspicion that a patient has meningococcal meningitis, go ahead and give the antibiotic as soon as you can. Do not wait for a spinal tap. Do not wait for other test results to come back. Okay. Then once the test results begin coming back, and it turns out either that the patient really did not have meningococcal meningitis, but they had something else, or that it is in fact meningococcal meningitis, that it is sensitive to an older, narrower spectrum antibiotic that can be used, then go ahead and change your antibiotics. But meningococcal meningitis is one of those extreme life-threatening bacterial infections for which antibiotics can make a huge difference. And yes, if I was suspecting meningococcal meningitis, don't wait for testing.
Okay, and we have time for this one last question. If a lab result comes back with all resistant organisms, is it wise to treat with an ABT in the hopes that the symptoms will decrease? Maybe the ABT ordered could be something that worked in the past.
So the question comes, what happens if your lab comes back showing, hey, this is not sensitive to any of our antibiotics? The first thing I would do is I'd ask the lab, first off, I'd call the lab and make sure it wasn't a lab error and that truly was resistant, because truly pan-resistant organisms are still relatively rare. The second thing I would ask the lab is, can you go ahead and can you test against antibiotics that you don't normally test against? Because as I mentioned, you can't possibly test against all antibiotics when you're doing a culture insensitivity. So if the lab could check against unusual or different antibiotics, you may find something that is sensitive. It is still at this point, luckily, unusual that we do not find at least a single agent that it would be sensitive to. So the first thing I would go back to my lab. The next thing I'd go to talk to my infectious disease consult. And if truly there was nothing that was all sensitive and you had an antibiotic that worked in the past, then I'd say go ahead and try it. But you certainly hope not to be in that position.
Okay, great. Thank you. Dr. Lifshitz, that's the end of the questions that have come in. Thank you so much. Again, this is always a valuable talk, and I know participants really get a lot out of this, so thank you. For those that are still remaining, I just want to remind you that an evaluation will be emailed out by the end of today. Certainly for those of you that are seeking continuing ed credits, please be sure to complete that, and we always welcome your feedback and suggestions for future programming. And I also want to ask you to be on the lookout for an announcement for our program on our next webinar on December 16th at 11 a.m., same time, with Dr. Michael Steinberg, who's from our tobacco, sorry, I just lost the name, the tobacco control program here at the university. He'll be speaking on e-cigarettes and the current status with lung disease and what's known about that thus far. So with that, thank you all for participating. Dr. Lifshitz, thank you again. And I hope you all have a great weekend. Have a good night.
Yep, and thank you, and happy Antibiotic Resistance Week, everybody.
Thank you. Have a good day.